Okay, so let's unpack this. I want you, the listener, to picture something completely ordinary. Maybe you're even doing it right now as you listen to us. You're eating a meal.
Right, yeah, like a sandwich or something.
Exactly. A sandwich, maybe an apple on the side, a handful of chips. You chew, you swallow, and you just, completely forget about it. You go back to driving or working or, I don't know, walking the dog.
As you should, really.
Right. But inside your body, the absolute second that food hits your digestive tract, this invisible, incredibly high stakes chemical balancing act just kicks off. Your body is suddenly working furiously just to process that food.
It's turning it into energy.
Yeah, turning it into energy, and most importantly, keeping that sudden influx of energy from literally becoming toxic to your own bloodstream.
It truly is a biological high-wire act. I mean, we take it completely for granted, this seamless transition from a physical meal on a plate to microscopic cellular fuel.
Oh, completely.
But the biological machinery required to make that happen, to maintain what the medical field calls glucose homeostasis, it's just staggering in its complexity.
Hmm.
If one single component of that system is, slightly out of tune, the entire body feels the shockwave.
And that is exactly our mission for this deep dive. We are looking at a brilliantly detailed pharmacological text today, specifically a massive breakdown on insulin and other antidiabetic drugs.
The very comprehensive source.
It really is. So our goal today is to demystify how your body manages its internal energy grid. And more importantly, we're going to look at how medical science steps in with just sheer mind-blowing ingenuity when that biological system breaks down.
Because the sources we are digging into today, they do so much more than just list a bunch of unpronounceable medications. They actually trace a story of desperate human innovation.
Desperate is the right word for it, yeah.
We are going to look at the historical reality of harvesting insulin from livestock, the leap to genetically modifying human molecules in a lab, all the way to synthesizing compounds originally found in the venom of desert reptiles.
Which is still just wild to me.
It's incredible. And every ounce of this effort, every scientific breakthrough, has been directed at solving the incredibly complex puzzle that is diabetes mellitus.
So whether you have a personal connection to diabetes, and statistically, looking at the numbers today, almost all of us do, or you just have this deep curiosity about human biology, stick with us.
It's a fascinating journey.
Because by the end of this conversation, it is going to completely change how you view your body's energy system. Every time you take a bite of food, you're going to visualize the microscopic machinery we're about to discuss.
I certainly do every single time I eat now.
Same here. But before we can talk about how to fix a broken machine, we have to understand how the machine is supposed to work in the first place. And that takes us to an organ tucked away deep in your abdomen, sitting right behind your stomach, the pancreas.
Ah, the pancreas.
Yeah, I always picture the pancreas as just this, I don't know, spongy filter, but the sources paint a very different picture.
They do. The pancreas is a fascinating piece of anatomy because it essentially operates as a dual factory. It has two completely distinct jobs that are performed simultaneously,
Yeah.
and it uses entirely different tissues to do them.
Okay, so what's the first job?
Well, the vast majority of the pancreas, what we call the exocrine portion, is dedicated to raw digestion. It just pumps out heavy-duty digestive enzymes directly into the intestines.
Like industrial solvents, almost.
Pretty much. We're talking about things like pancreatic amylase to break down the carbohydrates from that sandwich you ate, trypsin and chymotrypsin to dismantle the proteins, and pancreatic lipase to break down the triglycerides or, the fats.
So that's the heavy machinery factory, just churning out the chemicals to break down our food into base components?
That is the bulk of the organ, yes. But scattered among this massive churning exocrine factory are millions of tiny, highly specialized clusters of a totally different kind of tissue, endocrine tissue.
And these have a special name, right?
Yeah, these clusters are called the islets of Langerhans. And despite making up only 1 to 2% of the total mass of the pancreas, these tiny islets are the absolute control room for the body's entire glucose network.
Just 1 or 2%.
Exactly. Within these highly secured microscopic hubs, there are 4 distinct types of cells, each communicating with the others and secreting different hormones into the blood.
Okay, let's map out this control room. I'm going to guess they don't all just shout the same commands at the body. Who are the distinct players here?
The main two actors locked in a constant dynamic tension are the alpha cells and the beta cells. Alpha cells make up about 17% of the islet mass.
Okay, 17%.
And their dedicated job is to secrete a hormone called glucagon. Glucagon's primary role is to raise your blood sugar levels when they start to dip.
Got it. So alpha equals glucagon, rings the alarm, raises the sugar.
Then you have the beta cells. These are the overwhelming majority, making up roughly 70% of the islet mass. They secrete insulin, which does the exact opposite. It lowers blood sugar levels by forcing the body to absorb it.
Okay, I have to stop you there. Why the massive imbalance?
What do you mean?
Well, if they're playing tug of war with my blood sugar, why does the body dedicate 70% of its resources to the insulin side and only 17% to the glucagon side?
The reason for that imbalance tells you everything you need to know about human evolution.
Really? How so?
Historically, our biggest existential threat as a species wasn't eating too much cake, it was starvation. The human body is fundamentally designed to scavenge, absorb, and store every single calorie it can find.
Oh, that makes sense.
Right. And insulin is the ultimate storage hormone. So the pancreas dedicates the vast majority of its real estate to the hormone that helps us pack away energy for the lean times. We are biologically biased towards storage.
That makes total sense. We are built for a world of scarcity, but we live in a world of drive thrusts.
Unfortunately for our biology, yes.
Okay, so we have alpha and beta playing tug of war. Who else is in the islet?
To round out the room, you have delta cells, which make up about 7% of the islet. They secrete somatostatin, which acts as a sort of master brake for the whole system.
A break, like slowing things down.
Exactly. It actually inhibits the release of both glucagon and insulin, preventing wild, unchecked swings in either direction.
Oh, so it keeps the peace?
Precisely. And finally, the remaining tiny fraction are F cells, which secrete a substance called pancreatic polypeptide. This primarily regulates those heavy-duty digestive enzymes we mentioned earlier, keeping the exocrine factory in check.
I want to evolve a metaphor here. The pancreas isn't just a microchip room hidden inside a factory. It's more like the pancreas is a massive, roaring industrial boiler. That's the digestion part. But the islets of Langerhans are the tiny, hypersensitive thermostat strapped to the side of it.
That is an excellent way to conceptualize it.
Right, because if the thermostat breaks, the boiler either freezes over or completely explodes.
Exactly. The constant, delicate, negative feedback loop running through that thermostat is what keeps you alive. Let's examine how the glucagon side of the thermostat works first.
Okay, the alpha cells.
Right. If your blood glucose levels drop, say you're exercising heavily, or you simply haven't eaten in several hours, your body senses this immediately. Certain triggers, like sympathetic nervous stimulation or even eating a high-protein meal rich in amino acids but low in carbs, will stimulate the alpha cells to release glucagon.
So think of glucagon as an emergency flare shot up to the liver.
Yes, an emergency flare to the liver.
So if glucagon shoots the flare, what does the liver do? I always imagined the liver just had a tank of raw sugar inside it and it just opened a floodgate.
It's actually a much more active metabolic process than just opening a gate. The liver responds to glucagon in two distinct ways.
Okay, what's the first?
First, it takes its stored form of energy, which is a complex branched molecule called glycogen, and aggressively breaks it down into individual usable glucose molecules. That biological process is called glycogenolysis.
Glycogenolysis. So it chips away at the frozen reserves.
Yes. But the second thing it does is even more remarkable. Glucagon commands the liver to literally manufacture brand new glucose from scratch,
Wait, I'm scratch?
using raw materials like lactates and amino acids floating in the blood. That manufacturing process is called gluconeogenesis. By doing both breaking down reserves and manufacturing new supply, the liver releases a massive surge of glucose into the bloodstream to keep your brain and skeletal muscles fueled.
That is intense. But there has to be an off switch to that emergency flare, right? If the liver just keeps manufacturing sugar indefinitely, your blood turns to syrup.
The off switch is the rising blood sugar itself. What's fascinating here is that as hyperglycemia develops, meaning high blood sugar, that very glucose acts as a signal back to the alpha cells to shut down.
So the sugar itself turns off the alarm.
Exactly. Combined with the somatostatin released by the delta cells, the glucagon secretion is inhibited. The system recalibrates. If that blood glucose-dependent negative feedback mechanism fails, the alpha cells simply continuously pump out glucagon.
And then you end up with severe, damaging hyperglycemia.
It is a tightrope walk happening inside you every second of every day.
Now, here is a crazy detail from the source material that I absolutely did not see coming. We think of glucagon strictly as this internal hormone doing this internal balancing act, but it's actually isolated and used as a medical treatment, right?
It is an incredibly potent medical tool, yes. Therapeutically, if a patient with type 1 diabetes accidentally administers too much insulin, their blood sugar can crash so fast that they fall into severe hypoglycemia.
Which is incredibly dangerous.
It can quickly lead to a hypoglycemic coma and brain death. In that emergency scenario, a fast intramuscular injection of synthetic glucagon can save their life by forcing their liver to instantly dump its glucose reserves, counteracting the insulin overdose.
Wow.
But the clinical applications go beyond just diabetes. Surprisingly, glucagon is routinely used by radiologists as an aid for X-ray and MRI scans of the gastrointestinal tract.
I read that and stared at the page for a minute. Why an MRI? What does my blood sugar have to do with getting a scan of my stomach?
The mechanism there is entirely independent of blood sugar. Glucagon happens to have a profound, localized side effect. It completely relaxes the smooth muscle of the gut and temporarily paralyzes the motility of the intestines.
It paralyzes the gut.
Temporarily, yes.
Yeah.
If a radiologist is trying to capture a perfectly crisp, high-resolution image of a bowel tumor or an intestinal stricture, normal digestion causes movement artifacts on the scan.
Like a blurry photo.
Exactly. A quick shot of glucagon perfectly freezes the entire gastrointestinal tract, allowing for a crystal-clear image.
That is wild. The body's biological emergency sugar flare is also a chemical pause button for your intestines.
It's a very handy dual-purpose tool.
Okay, so we have glucagon, raising the sugar and freezing the gut. Let's shift our focus to the undisputed star of the pharmacological show, the hormone that lowers the sugar, insulin.
The beta cell's primary product.
Right. We established that the beta cells, that massive 70% majority in the islets, are responsible for making and releasing insulin. But reading through the biosynthesis section of this text, it is incredibly convoluted. I always pictured the cell just synthesizing a hormone and squeezing it out like a tube of toothpaste.
If only it were that simple.
Yeah.
The reality is a highly orchestrated, multi-stage assembly line, primarily because the final insulin molecule is incredibly fragile and requires very specific folding to function.
So how does it actually start?
The beta cell doesn't just print a finished insulin molecule. It starts by translating its DNA into a massive, clunky precursor molecule called preproinsulin.
Preproinsulin, that sounds like the rough draft of a rough draft.
It essentially is. Almost immediately after it is formed in the rough endoplasmic reticulum of the cell, enzymes called endopeptidases cleave a specific signaling piece of it off.
So they trim the fat.
By removing that piece, the molecule transitions into what we call proinsulin. This proinsulin is then packaged into vesicles and shipped over to the Golgi apparatus inside the cell. The Golgi apparatus, taking me right back to 10th grade biology. The packaging, shipping, and receiving center of the cell. What happens to the proinsulin once it gets to the shipping department?
This is where the structural engineering happens.
The proinsulin molecule consists of 3 distinct parts. You have an A chain, which is exactly 21 amino acids long, and a B chain, which is 30 amino acids long.
Okay, A and B.
But connecting these two functional chains is a long, winding third segment called the C-peptide.
With C simply standing for connecting.
Precisely that, the connecting peptide. You see, the A and B chains eventually need to bind to each other, but they have to align perfectly so that very specific chemical bonds, disulfide cross bridges, can form between the exact right amino acids.
And if they don't align?
If they misalign by even a fraction, the insulin is useless. The C-peptide's job is to act like a rigid biological scaffolding. It holds the A and B chains in the exact spatial orientation required to let those disulfide bridges lock into place. Once those bridges are perfectly secured and the A and B chains are welded together, the C-peptide's structural job is done. Enzymes called proteases come in and literally snip the scaffolding away. What you are left with is the final, active, functional insulin molecule.
Okay, let me make sure I'm visualizing this correctly. The cell builds a massive temporary scaffolding, the C-peptide, just to hold these two fragile little A and B chains in the perfect shape while they get chemically bolted together.
Correct.
And the absolute second they are secure, the cell just kicks the scaffolding away.
That is exactly the mechanism. And the fact that the cell operates this way provides modern medicine with an incredibly important clinical tool.
How so?
Because the active insulin and the discarded C-peptide scaffolding are packaged together in the secretory granules inside the beta cell. Whenever that cell ultimately releases insulin into the blood, it releases an exact equimolar amount of C-peptide right along with
Oh,
it.
so they're a one-to-one package deal.
For every 1 molecule of insulin released, 1 molecule of C-peptide enters the circulation.
Which means they travel together. But why does a doctor care about the discarded scaffolding? Why not just measure the insulin itself?
Because measuring endogenous insulin, the insulin your body makes itself, is notoriously difficult. The body clears active insulin from the blood incredibly fast.
Really? How fast?
Its plasma half-life is less than 10 minutes. The liver destroys up to 60% of it on its very first pass through the hepatic portal vein. It fluctuates wildly minute by minute.
So it's basically a ghost.
Exactly. But C-peptide is different. It doesn't bind to insulin receptors, it isn't metabolized by the liver in the same way, and it hangs around in the bloodstream significantly longer.
Oh, I see where this is going.
So if an endocrinologist wants to know exactly how much insulin your pancreas is actually capable of producing on its own, the C-peptide provides a stable, highly accurate proxy.
Oh, that is absolutely brilliant because if you have a diabetic patient who is injecting artificial insulin, a standard blood test looking for insulin wouldn't be able to tell the difference between the insulin their own body made and the insulin they just injected from a pharmacy vial.
Precisely.
But the injected insulin from the pharmacy doesn't have the C-peptide scaffolding attached to it.
The clinical utility of that cannot be overstated.
Mm-hmm.
C-peptide is the biological receipt that proves your own beta cells made the transaction.
That's a great way to put it.
It allows us to distinguish between type 1 diabetics who make absolutely no C-peptide and type 2 diabetics who might actually be making high levels of C-peptide due to insulin resistance. It's an indispensable diagnostic marker.
My mind is completely blown by the elegance of that. Okay, so the cell has manufactured the insulin, it has clipped off the C-peptide, and now it stores the insulin until your body needs it. The text mentions they are stored in a really specific structure inside the granules.
Yes, they don't just float around loosely. They form highly organized, complex hexamers.
Hexamers, meaning 6 parts.
Exactly. 6 individual molecules of insulin wrap themselves tightly around 2 atoms of zinc. This zinc hexamer structure is incredibly stable, allowing the beta cell to stockpile massive amounts of insulin safely without it degrading.
Okay, so the insulin is locked, loaded, and stockpiled in the beta cell. Now we arrive at my absolute favorite part of the source material, the release mechanism.
It's quite the process.
How does the pancreas actually know when to deploy this stored insulin into the blood? Because reading the textbook outline of this cellular cascade, it honestly plays out like a bank heist movie.
The sequence of cellular events is breathtaking, really. It is a perfect translation of metabolic energy into a physical electrical command. Let's walk through the heist step by step.
Let's do it.
The entire cascade is triggered when your blood glucose rises above a very specific baseline threshold, specifically above 70 milligrams per deciliter.
Okay, so you, the listener, have eaten that sandwich. The bread digests down into pure glucose, hits your bloodstream, and that concentration crosses the 70 threshold. Does the sugar just bump into the beta cell and knock the insulin loose?
Far from it. The beta cell actively pulls that glucose inside to examine it. Sitting on the surface membrane of the beta cells are specific, specialized doorways called GLUT2 transport.
GLUT2 doors.
The glucose uses these GLUT2 doors to flood into the beta cell. Once inside, the beta cell immediately begins metabolizing the glucose. Through a complex series of enzymatic steps involving glucose 6-phosphate and pyruvate, the cell burns that glucose to generate ATP.
ATP, adenosine triphosphate, the fundamental energy currency of all living cells.
Correct. So as the cell digests this influx of glucose, the internal concentration of ATP starts to rapidly rise. Now, sitting on the outer membrane of this very same beta cell is a completely different, highly sensitive channel, an ATP-sensitive potassium channel.
So a different door entirely.
Right. Under normal fasting conditions, this potassium channel is wide open. It lets positively charged potassium ions freely flow out of the cell, which keeps the inside of the cell in a resting, electrically negative state.
Okay, potassium flows out, cell stays negative.
But when those internal ATP levels spike, the ATP molecules physically bind to these potassium channels and force them to close.
Wait, so the metabolic energy itself, the ATP generated from the sandwich, acts as the physical key to lock the potassium door.
It absolutely does. And the consequence of that is immediate. Because the door is locked, the positively charged potassium can no longer escape.
So it just piles up inside.
Exactly. It starts pooling and building up inside the cell. As the positive charge accumulates, the inside of the cell becomes progressively less negative. In cellular biology, this shift in electrical charge is called membrane depolarization.
Okay, let's unpack this. We have translated a sandwich into a rising positive electrical charge inside a microscopic cell in the pancreas. What does that electrical charge do?
That electrical shift is the crucial command signal. When the membrane depolarizes to a specific voltage, it triggers a third set of doors to violently open,
Another set of doors.
voltage-dependent calcium channels. Because the internal electrical voltage just changed, these calcium doors fly open, and positively charged calcium ions from the outside fluid absolutely flood into the beta cell.
And what does this sudden flood of calcium accomplish?
The calcium influx is the final physical trigger. The sudden presence of high intracellular calcium activates proteins that command those zinc insulin hexamers we talked about to migrate to the edge of the cell, fuse with the outer membrane, and physically dump their insulin payload directly into the bloodstream.
Like taking out the trash, but it's insulin.
Basically, it's a process called exocytosis.
I'm speechless at the mechanics of this. Wait,
Oh.
so the glucose literally has to enter the cell, undergo full metabolic digestion into ATP energy just to flip an electrical switch, which then opens a calcium trap door, which finally lets the insulin out.
That is the sequence, yes.
It is literally a combination safe. Glucose is the first dial, ATP is the second dial, and calcium is the final satisfying click that opens the vault.
The combination safe is a flawless analogy. The beta cell isn't just passively bobbing in the blood, blindly guessing at your sugar levels. It actively samples the blood, metabolizes it, translates that chemical energy into a precise electrical voltage, and executes a physical release based on that exact voltage.
It's doing math constantly.
It recalculates this math continuously, every single second of your life, to keep your blood sugar in the narrow window of survival. When you are fasting, ATP levels drop. The potassium doors swing open, the cell repolarizes, the calcium door slams shut, and insulin release stops.
And the moment you take a bite of food, that whole combination safe sequence fires back up.
Exactly.
That is awe-inspiring biology. And unfortunately, understanding the sheer elegance of that lock and key mechanism perfectly sets up the tragedy of what we need to discuss next, which is system failure.
Yes, when the mechanism breaks down.
Because now that we know how beautifully the machine runs, we have to look at what happens when the lock rests over, or the key just goes missing entirely. We have to talk about the pathology of diabetes mellitus.
The disease state is devastating, precisely because it breaks that elegant feedback loop.
Yeah.
You know, the term diabetes mellitus historically translates from Greek and Latin as a siphon of honey.
A siphon of honey? That sounds oddly poetic for a disease.
Ancient physicians named it that because patients would produce massive volumes of sweet-tasting urine. Fundamentally, diabetes is a state of chronic, unmanaged hyperglycemia.
Too much sugar in the blood.
Right. It occurs either because the beta cells have been destroyed and there is a massive decrease in circulating insulin, or because the body's target tissues have simply stopped responding to the insulin that is still there.
So looking at the sources, they outline these classic hallmarks of the disease, often referred to in medical circles as the three polys: polyuria, polydipsia, and polyphagia. Let's translate those terms for the listener and, more importantly, explain why they happen. Let's start with polyuria.
Polyuria simply means excessive urine production.
Right, and I think a lot of people know that undiagnosed diabetics often have to run to the bathroom frequently. But what is the actual physiological mechanism tying high blood sugar to a full bladder? Does sugar just irritate the bladder?
No, it has nothing to do with bladder irritation. The origin is entirely in the kidneys. The kidneys are your blood's filtration system. They constantly filter massive amounts of glucose out of the blood, and normally, highly efficient transporters in the kidneys immediately reabsorb almost 100% of that glucose back into the bloodstream.
Because, again, the body doesn't want to waste free calories.
Exactly. But in an uncontrolled diabetic state, the blood glucose levels are so astronomically high that they physically overwhelm those kidney transporters. The system maxes out.
It just can't catch it all.
Consequently, the excess glucose spills over into the urine.
Okay, so there is sugar in the urine. Why does that make you pee more volume?
Because glucose is an osmotically active molecule. In biology, where solutes like sugar or salt go, water follows. It's basic osmosis.
Oh, right, like putting salt on a slug, it draws the water out.
Precisely. So as all that thick glucose travels through the microscopic tubules of the kidney on its way to the bladder, it literally pulls massive amounts of water out of the surrounding tissues and blood vessels to dilute itself.
Wow.
This osmotic drag pulls liters of water out of the body, causing the profound polyuria.
Which then creates a domino effect that perfectly explains the second polydipsia. If your kidneys are dragging all the water out of your blood and forcing you to urinate it away, you become severely dangerously dehydrated. Your blood volume drops and your brain screams at you with an intense, unquenchable thirst.
Exactly the mechanism. The polydipsia is a desperate compensatory response to the polyuria.
And the third one, polyphagia.
Polyphagia, which means excessive hunger or eating, happens because of a cruel metabolic irony.
Yeah.
Even though the patient's blood is absolutely swimming in excess glucose, they lack the functional insulin to unlock the cellular doors.
The keys are missing.
Right. The glucose cannot enter the skeletal muscles or the adipose tissue. So at cellular level, the body is literally starving to death.
Starving while surrounded by food.
Exactly. The brain interprets this cellular starvation as fasting and ramps up the appetite to ravenous levels.
Starving to death while floating in a sea of plenty. It is such a dark irony. Now, the text rigorously breaks down the two major types of diabetes, type 1 and type 2, because the underlying failures are completely different. Let's start with type 1.
Older literature used to call it insulin-dependent diabetes mellitus, or juvenile onset diabetes.
Right. What exactly is failing in a type 1 patient?
Type 1 diabetes is fundamentally an autoimmune disease. For reasons that involve a complex mix of genetic predisposition and environmental triggers, researchers frequently point to viral infections like the echovirus.
An echovirus? What's that?
It's a common gastrointestinal virus that might accidentally trick the immune system into friendly fire.
Oh, so the body gets confused.
Exactly. The body's own immune system turns rogue. It actively hunts down, attacks, and destroys the beta cells in the pancreas. Over 95% of type 1 cases are this specific autoimmune-mediated type, clinically known as type 1A.
And once they're gone,
Because the beta cells are physically eradicated, the patient is left with an absolute lack of insulin. The manufacturing plant has been burned to the ground.
and without insulin, the body doesn't just sit there quietly, it panics. The source material outlines this terrifying rapid cascade called diabetic ketoacidosis, or DKA.
A very severe complication.
Can you walk us through the physiological reality of DKA? Because looking at the biochemistry, it seems like the body's emergency backup plan just completely backfires and poisons itself.
That is the most accurate way to describe it. In an uncontrolled type 1 diabetic, because there's zero insulin present to let glucose into the skeletal muscles and body cells, the cells are screaming for calories.
You're starving.
Right. The brain realizes the glucose isn't working, so to compensate and prevent starvation, the body drastically shifts to its backup fuel source, fat. It accelerates the massive breakdown of adipose tissue, liberating fatty acids into the blood to be metabolized into ATP.
Which on the surface sounds fine. I mean, we burn fat for energy all the time when we work out.
We do, but it is entirely a matter of scale and speed. When body burns fat, it generates a metabolic byproduct called acetyl-CoA. Under normal circumstances, acetyl-CoA quietly enters the Krebs cycle, the cell's internal engine, to be cleanly processed into energy.
But in DKA.
In this state of absolute unchecked carbohydrate starvation, the fat breakdown is so rapid and so aggressive that the Krebs cycle becomes completely overwhelmed. It physically cannot handle the sheer volume of acetyl-CoA flooding the system.
So the engine is flooded. What happens to all that overflow acetyl-CoA?
The liver has to divert the overflow. It takes those excess acetyl-CoA molecules and links them together to form what we call ketone bodies.
Ketone bodies.
Specifically, compounds named acetoacetate and beta-hydroxybutyric acid. The liver dumps these ketone bodies into the blood as an alternative fuel for the brain. The critical failure is that, as their chemical names imply, these ketone bodies are highly acidic.
Acidic blood. That sounds incompatible with human life.
It is a profound, life-threatening emergency. The rapid accumulation of these ketone bodies leads to metabolic acidosis. The pH of the patient's blood drops, becoming acidic.
And what does that do to the body?
This acidic environment actively decreases the brain's ability to utilize what little energy it has, leading to confusion, lethargy, and rapidly progressing to a deep coma and death if not intervened upon.
That's terrifying.
It gets worse. Furthermore, as the levels rise, one of those ketone bodies, acetoacetate, spontaneously breaks down into acetone.
Wait, acetone, like nail polish remover?
Exactly like nail polish remover. The acetone is highly volatile and is actually excreted through the lungs as the patient desperately hyperventilates to blow off the acid. This is why patients in DKA often have a very distinct, sweet, fruity, almost nail polish remover odor to their breath.
A fruity odor on the breath, profound systemic dehydration from the polyuria, and blood turning acidic enough to shut down the brain. It is an absolute physiological crisis. Now, how does that acute crisis differ from what happens in type 2 diabetes? Because I know type 2 is far more common, but you rarely hear about DKA in type 2 patients.
The pathology of type 2, historically referred to as non-insulin dependent or maturity onset diabetes, is entirely different.
Mm.
It typically develops in adults over 40 and is highly associated with obesity and sedentary lifestyles.
So the manufacturing plant isn't burned down in this one?
Right, in type 2, the primary problem isn't that the pancreas has been destroyed. The beta cells are still there and they are still manufacturing insulin.
Then what's the issue?
The core failure is peripheral resistance. The target cells in the muscles, fat, and liver become relatively insensitive to the insulin. To use our analogy, the key is still being produced, but the keyholes on the cellular doors are heavily rusted and jammed.
And because they still have some functional insulin circulating in their blood, even if it's not working perfectly, it prevents them from going into that terrifying DKA cascade, right?
That is the crucial distinction. In type 2 diabetes, there is usually just a tiny baseline amount of endogenous insulin successfully getting its signal through. And it turns out, you only need a very small amount of insulin signaling to prevent the massive, unchecked breakdown of body fat.
So it holds off the ketoacidosis.
Exactly. Type 2 patients rarely develop ketoacidosis,
Huh?
but they are at risk for a different, equally lethal emergency, a hyperosmolar coma.
Hyperosmolar coma, break that down for me. If they aren't turning their blood acidic, what is the threat?
The danger lies in the insidious nature of it. Because a type 2 patient isn't breaking down fats into highly acidic ketones, they might not feel acutely, violently sick right away. So their blood sugar can just rise and rise and rise over weeks, sometimes reaching astronomical levels,
Like how high?
often over 600 or 800 milligrams per deciliter, entirely undetected.
Oh my God.
This severe, prolonged hyperglycemia leads to that profound osmotic diuresis we discussed earlier, the massive water loss through the urine. They become so severely dehydrated over such a long period that their blood literally becomes thick, viscous, and hyperosmolar.
Like a thick syrup.
It literally turns into a thick syrup. This extreme hyperosmolarity pulls fluid completely out of the brain cells, leading to a coma. It is a clinical emergency requiring very fast but incredibly careful fluid replacement and insulin therapy.
That is sobering. Just picturing the blood becoming so thick with sugar that it dehydrates the brain, it really clarifies the stakes. And even if a patient manages to avoid these acute hospital-level emergencies, the chronic day-to-day effects of walking around with high blood sugar are devastating over a timeline of years.
They absolutely are.
The sources divide these chronic complications into microvascular, meaning small blood vessels, and macrovascular, meaning large blood vessels.
The long-term vascular damage is where diabetes exacts its heaviest toll. Over a decade or more, poor glycemic control absolutely shreds the circulatory system.
Let's start with the big ones, the macrovascular.
The macrovascular complications include accelerated atherosclerosis, a rapid hardening and narrowing of the major arteries leading to massively increased rates of heart attacks, strokes, and peripheral artery disease.
Just destroying the major highways of the body.
Right. This is heavily driven by diabetic dyslipidemia, a state where the patient suffers from elevated triglycerides and low-density lipoprotein, or LDL cholesterol, alongside the high sugar.
But the microvascular damage, the slow destruction of the tiny microscopic capillary beds, that seems to be specifically tied directly to the high glucose itself, not just cholesterol.
It is.
The text dives into a biochemical mechanism involving something called sorbitol. This seems incredibly important to understand why diabetics lose their vision or their kidney function.
It is perhaps the most crucial biochemical mechanism of chronic diabetic damage. Certain tissues in your body, specifically the lens of the eye, the delicate filtration tufts in the kidneys, and the Schwann cells that insulate your peripheral nerves, do not require insulin to absorb glucose.
So they don't even have a lock on the door.
Exactly. When blood sugar is high, glucose just floods freely into these cells. Once inside, an enzyme called aldose reductase acts on this excess glucose and converts it into a sugar alcohol called sorbitol.
Okay, so the cell turns the sugar into a sugar alcohol. Why is that bad?
Because sorbitol is a highly hydrophilic molecule that cannot easily cross cell membranes to escape.
It's trapped.
It gets trapped inside the cell. As sorbitol accumulates to toxic levels over years, it causes massive osmotic stress, pulling water into the cells and causing them to swell and malfunction. In the tiny microcapillaries, this sorbitol accumulation causes the basement membrane of the endothelial cells to drastically thicken.
If you thicken the walls of a microscopic hair-thin blood vessel, you are going to strangle the blood supply. The tube will just close up.
And the consequence of that strangulation is profound tissue hypoxia or oxygen starvation.
Which leads to the major complications.
Yes, this exact mechanism is the root cause of diabetic retinopathy. where the starved retina grows fragile new blood vessels that hemorrhage, leading to blindness. It causes diabetic nephropathy, where the kidney's filtration units scar over, leading to end-stage renal failure and the need for dialysis.
And neuropathy as well, right?
Exactly. It causes diabetic neuropathy, where the nerves literally lose their protective myelin sheathing and die, leading to the loss of sensation in the feet and, tragically, often resulting in amputations.
It's heartbreaking.
Furthermore, that excess sorbitol deposits directly inside the lens of the eye, drawing in water, making the lens cloudy, and causing rapid onset cataracts.
So keeping that blood sugar in check is not just about avoiding a coma today. It is quite literally a matter of preserving your vision, preserving your kidneys, and keeping your limbs attached over the next 20 years.
It's about preserving your entire quality of life.
Which perfectly transitions into a really interesting diagnostic tool mentioned heavily in the text, glycosylated hemoglobin, or HbA1c. I hear this term constantly in pharmaceutical commercials. Lower your A1C. But what does that actually mean?
It's a crucial metric.
Right, but if I'm a diabetic, why do I care about an HbA1c test when I can just prick my finger right now, look at a digital meter, and see exactly what my blood sugar is?
Well, the limitation of the finger prick is that it is strictly a snapshot. It only tells you what your blood sugar is at that exact, isolated moment in time.
Just a single frame of a movie.
Exactly. But as we've discussed, glucose levels vary wildly on a day-to-day, hour-to-hour, even minute-to-minute basis, depending on what you ate, if you exercised, or if you're stressed.
Sure.
If an endocrinologist wants to know if your diabetes is actually under control and if you are protecting your microvessels from sorbitol damage, a snapshot isn't enough. They need to see the trend. They need a security camera recording the last 3 months.
And HbA1c is the security camera footage. How does that biologically work?
It's an incredibly clever exploitation of biology. Red blood cells circulate in your blood, and their primary component is the protein hemoglobin, which carries oxygen.
Oh, okay, hemoglobin.
When blood glucose levels are elevated, that excess glucose literally crashes into the hemoglobin and chemically binds to it. It's a non-enzymatic process called glycation.
So the sugar just sticks to it.
Yes. Specifically, the glucose permanently attaches to the valine amino acid at the terminal end of the hemoglobin beta chain. Once that glucose is stuck on there, the molecule is forever altered into what we call glycosylated hemoglobin, or HbA1c.
Okay, so the sugar just physically coats and sticks to the red blood cells as they float by.
Yes, and the crucial factor is that it's a permanent attachment for the entire lifespan of that specific red blood cell.
Wait, how long do they live?
Now, how long does an average red blood cell live before the spleen recycles it? About 120 days.
4 months.
Therefore, the percentage of hemoglobin that has become glycated is directly proportional to the average glucose concentration the cells have been swimming in over that 120-day lifespan.
So it's an average score.
Exactly. By drawing a vial of blood and measuring the percentage of HbA1c, a doctor gets a highly accurate, uncheatable, integrated measure of what the patient's blood sugar has been doing over the past 2 to 3 months.
That is such a brilliant cheat code for medicine. You cannot hide from the HbA1c test.
No, you really can't.
If a patient eats a salad the day of their doctor's appointment, their finger prick might look perfect. But if they were drinking soda and spiking their blood sugar for the 2 months prior, their red blood cells are still carrying the physical evidence.
No. It reveals the whole truth.
The text notes that a normal, non-diabetic HbA1c is around 6%, which equates to an average daily blood glucose of about 110 milligrams per deciliter. And the aggressive clinical goal for diabetics is to keep that A1c below 7%, to proactively prevent all those microvascular sorbitol complications we just discussed.
The development of the A1C test completely shifted the paradigm of diabetes management from frantically reacting to daily numbers to strategically managing a long-term, stable metabolic state.
Okay, so we've established the intricacies of the machine, the mechanism of the combination safe, and the devastating systemic consequences when the system fails.
The foundational knowledge.
Right. Now we arrive at the most vital part of our deep dive, the insulin arsenal. For type 1 diabetics who have absolutely no beta cells left, and for severe type 2 patients whose pancreas is just totally exhausted from decades of overwork, we have to provide the missing key. We have to give them external insulin.
We have to replace what's lost.
But looking at the historical reality, in the 1920s and 30s, it wasn't as simple as just synthesizing a human hormone in a sterile lab.
No, the early days of insulin therapy were genuinely fraught with peril. Before 1921, type 1 diabetes was an absolute death sentence, usually within months of diagnosis.
Months. Wow.
The breakthrough came when researchers realized they could extract insulin from the crushed pancreases of slaughtered cattle and pigs.
Cow and pig insulin.
Yes. Now, biochemically, beef insulin differs from human insulin by exactly 3 amino acids out of the 51 on the chain. Pork insulin is even closer. It only differs by 1 single amino acid.
I mean, one single amino acid difference out of 51. From a structural perspective, that seems close enough, right? The lock should still turn.
The lock turned and it saved millions of lives.
Yeah.
But the human immune system is incredibly ruthlessly precise. Even that slight 1 amino acid difference meant that these animal insulins were highly immunogenic to a human body.
It knew they were alien.
It recognized them as foreign. Over time, many patients developed massive amounts of neutralizing antibodies against the beef or pork insulin. This not only caused severe localized allergic reactions at the ingestion site's lipodystrophy, but it also led to massive systemic insulin resistance.
Because the body was fighting the drug.
Exactly. Sometimes patients required escalating doses of over 100 or even 200 units a day just to overwhelm the antibodies they were actively neutralizing the drug in their blood. Not to mention the later, very real fears of zoonotic disease transmission, like the panic surrounding mad cow disease.
Right. So science was backed into a corner. They had to find a way to make pure 100% human insulin without actually harvesting human pancreases, which is obviously a non-starter.
A huge ethical barrier, obviously.
And the solution they found in the late 1970s is arguably one of the most famous and consequential breakthroughs in the history of biotechnology.
The advent of recombinant DNA technology changed everything. Scientists figured out how to map the human proinsulin gene, synthesize it, and physically insert it into the DNA plasmids of E. coli bacteria or yeast cells like Saccharomyces cerevisiae.
They put human genes into bacteria.
Yes. When these genetically modified microbes multiply in massive fermentation vats, they essentially act as microscopic biological factories, obediently churning out vast quantities of human proinsulin.
That's amazing.
This precursor is then extracted, purified, and the C-peptide is chemically cleaved off exactly as it happens in the human body. What you are left with is pure, unadulterated, structurally identical human insulin. No allergies, no animal harvesting.
That alone is a miracle of modern science. But the pharmacologists didn't just pat themselves on the back and stop there because, as the texts explain, just handing a patient a vial of pure human insulin isn't enough to replicate the complex, dynamic way a healthy, living pancreas actually releases it.
It's about timing.
Right, the pancreas doesn't just dump a bucket of insulin once a day. So they started tinkering with the molecular structure of the insulin itself to change how fast or how slow it absorbs into the blood.
To mimic the natural basal and bolus rhythms.
Exactly. The sources break these modified insulins down into categories based on their duration of action. Let's start with the sprinters. The ultra-short or rapid-acting insulins. We're talking about brand names and molecules like insulin lispro, aspart, and glulisine. If it's already pure human insulin, why did they need to modify it to make it faster?
To understand the necessity of the rapid insulins, you have to remember how natural insulin prefers to exist in a vial. Just like in the human beta cell, pharmaceutical human regular insulin naturally clusters together to form those bulky zinc hexamers.
The six-packs.
Yes, the hexamers. When a patient injects regular human insulin into the subcutaneous fat under their skin, those massive 6-part hexamers take significant time to physically dissolve into the interstitial fluid, break down into pairs called dimers, and finally separate into single molecules, or monomers.
Because only the monomers are small enough to get into the blood.
Exactly. They are the only things small enough to cross the capillary walls and enter the blood.
So, injecting regular insulin creates a biological traffic jam at the injection site. It takes 30 to 45 minutes for the traffic to clear and the insulin to actually hit the bloodstream.
And the consequence of that delay is that patients had to inject their insulin 45 minutes before they even sat down to eat, which requires impossible levels of planning and leads to dangerous miscalculations.
Like if the food is late at a restaurant.
Exactly. So with ultra-short-acting analogs like lispro and aspart, pharmacologists went in and genetically swapped the position of specific amino acids on the insulin chain.
Just swap them around.
Yes. For example, in insulin lispro, they simply reversed the order of the amino acids lysine and proline at positions 28 and 29 on the B chain. This minuscule structural tweak does not affect how the insulin binds to the cellular receptor, but it physically prevents the insulin molecules from clumping together into hexamers in the vial.
So when the patient injects it, there is no traffic jam. It's already broken down into single monomer race cars.
It absorbs almost instantaneously. The pharmacological action starts within 15 to 30 minutes and peaks rapidly. This is absolutely perfect for meal times. A patient can take their shot right as the plate of food is placed in front of them, perfectly mimicking the rapid, combination-safe spike of natural insulin we discussed earlier.
Okay, so the rapid analogs like Lispro are the sports cars, fast start, fast stop, specifically designed to handle the sudden influx of carbohydrates from a meal. But you can't run a sports car engine 24/7. Your body also needs a constant low-level baseline of insulin just to keep the liver from dumping its emergency sugar reserves into the blood all day and all night.
The basal insulin requirement.
Right. And for that baseline, we look at the slower insulins. Let's talk about intermediate acting insulin, specifically NPH. I was reading the historical notes on this, and the fact behind it absolutely blew my mind. What does NPH stand for, and what on earth did they put in it to slow it down?
NPH stands for neutral protamine Hagedorn. Hans Christian Hagedorn was the Danish researcher who developed it in the 1930s. He realized that if you just inject insulin, it absorbs too fast.
We established that traffic jam wasn't slow enough.
Right, he needed a way to bind the insulin to something that would hold onto it and release it slowly. The secret ingredient he discovered was a modifier protein called protamine. And yes, as the text notes, protamine is a protein originally extracted from the sperm of river trout and salmon.
Fish sperm. You're telling me that for decades, diabetics were surviving by managing their blood sugar with a complex made of a human hormone chemically bound to fish sperm.
It sounds bizarre to modern ears, but the underlying biochemistry is highly effective. Protamine is a highly alkaline, arginine-rich, positively charged protein. Insulin, conversely, is negatively charged.
Ah, opposites attract.
Exactly. When you mix them together in a vial at a neutral pH, they aggressively bind to each other and form a cloudy, crystalline complex. When a patient injects this milky suspension subcutaneously, their natural tissue enzymes have to slowly, painstakingly degrade the protamine coating over many hours just to liberate the active insulin inside.
So it creates a slow release.
This enzymatic degradation slows the absorption down significantly, giving NPH a delayed onset and a sustained duration of action of about 16 to 20 hours.
It's essentially a biological time-release capsule. You wrap the drug in a fish protein so the body has to digest the wrapper first.
That's the exact mechanism. But NPH has a significant clinical flaw. Its absorption profile can be highly erratic. Because it's a suspension, it has to be perfectly mixed before every injection.
Like shaking up a snow globe.
Right. More dangerously, its release isn't flat. It tends to peak sharply in the middle of its duration, usually 6 to 8 hours after injection. If a patient takes NPH at bedtime to provide overnight baseline insulin, that peak hits right at 3 in the morning, which can cause severe, sometimes fatal nocturnal hypoglycemia while they are asleep.
Which means the pharmacologist had to go back to the drawing board to create the ultimate, perfectly smooth freight train of insulins, the true long-acting basal insulins.
The modern basal analogs.
We are talking about modern marvels like insulin glargine, detamir, and degludec. And I have to say, the sheer chemical genius of how they engineered glargine, marketed widely as Lantus, is my absolute favorite part of this entire deep dive. Walk us through the pH magic trick they pulled off here.
The engineering of glargine is a masterpiece of physical chemistry. The goal was to create an insulin that releases slowly and evenly over 24 hours, with absolutely no dangerous peaks.
How do you do that without fish protein?
To achieve this, scientists added 2 extra arginine amino acids to the B chain and swapped an asparagine for a glycine on the A chain. These specific changes shift the molecule's isoelectric point, the pH level at which the molecule is electrically neutral and therefore least soluble in water.
Okay, stick with me. Least soluble.
What that means in practical terms is that glargine is designed to be completely soluble, a perfectly clear liquid, but only in a highly acidic environment of pH 4.
Okay, so in the glass vial that the patient buys from the pharmacy, the fluid is kept highly acidic.
Yes, the solution in the vial is buffered to a strict pH of 4, keeping the insulin fully dissolved. But human subcutaneous tissue, the layer of fat under your skin where the injection goes, operates at a strict neutral physiological pH of 7.4.
Oh.
When the patient injects that clear, acidic liquid into their neutral tissue, the sudden drastic shift in acidity neutralizes the insulin. This causes the glargine molecules to literally fall out of solution.
What does that mean, fall out of solution?
They instantly clump together and form microscopic precipitates or tiny crystals right there in the tissue under the skin.
That is unbelievable. It literally turns from a liquid into a microscopic crystal depot inside your body the second you inject it.
It does. And because it is now locked in this dense crystalline form, it is highly stable. The edges of the crystal very slowly, predictably dissolve into the surrounding capillaries, providing a steady, sustained, completely peakless trickle of insulin into the blood for up to 24 hours.
It mimics the pancreas.
It mimics the natural, flat baseline insulin secretion of a healthy human pancreas almost perfectly, drastically lowering the risk of that dangerous middle-of-the-night hypoglycemia compared to the old NPH.
It is a biochemical magic trick. You inject an acid liquid, it turns into a slow-release crystal upon contact with your body's pH, and it feeds you life-saving hormone all day. What about the other long-acting ones mentioned, Detamir and Degludec? Do they form crystals under the skin too?
They achieve a similar long-acting result, but using completely different, equally clever molecular mechanisms. With insulin detamir, the scientists omitted an amino acid and attached a 14-carbon fatty acid chain myristic acid to the side of the insulin molecule.
The fatty tail.
Yes. When injected, this fatty tail seeks out and binds tightly to albumin, which is the most abundant transport protein circulating in your interstitial fluid and blood. The albumin acts like a taxicab fleet, holding tightly onto the insulin molecules and only slowly releasing them over time as the equilibrium shifts.
A fatty acid hitchhiker. And Degludec. The text says its duration of action can exceed 42 hours. How does a single injection last almost 2 days?
Degludec uses a complex specific spacer and a hexadecanidioic acid chain. When injected into the subcutaneous tissue, the phenol used as a preservative dissipates, causing the Degludec hexamers to link up end-to-end, forming massive, sprawling multi-hexamer chains.
Like a chain link fence.
It essentially weaves a highly stable, slow-dissolving subcutaneous mat of insulin under the skin that slowly sheds monomers from the ends. It provides a remarkably flat and consistent release profile for days, giving patients incredible flexibility if they accidentally delay a dose by a few hours.
So to recap the arsenal, we have the modified sports cars, Lispro and Aspart, that stay as single molecules for instant mealtime absorption. We have the legacy time capsules, NPH, wrapped in fish proteins. We have the crystal-forming pH magicians like Glargine, and we have the fatty acid hitchhikers like Decimir. The evolution of this is staggering.
It's a century of relentless optimization.
Before we move entirely away from insulin, I do want to touch on something the text mentions that sounds like a sci-fi utopian idea, but apparently was a massive commercial failure. Inhaled insulin.
Ah, yes, Exubera and Afrezza.
Right. I saw those brand names. The idea was to finally free type 1 diabetics from the tyranny of needles and let them just use an inhaler like an asthma patient. Why isn't everyone using this?
Well, the physiological rationale was incredibly sound. The human lungs have a massive alveolar surface area and a tremendous rapid blood supply, making the pulmonary bed an ideal route for the rapid absorption of peptide hormones.
Seems like a no-brainer.
And clinically, inhaled human insulin works very well. It absorbs rapidly, peaking almost as fast as the ultra-short-acting injectable analogs. But the real-world drawbacks were immense.
What happened?
Exubera, the first major attempt launched in 2006, utilized a delivery device that was the size of a large flashlight, which patients hated carrying around.
Yeah, nobody wants a flashlight in their pocket.
The dry powder frequently deposited in the back of the throat instead of the deep lungs, causing severe pharyngitis, persistent coughing, and erratic absorption.
And breathing a massive growth hormone directly into your delicate lung tissue probably raised some red flags.
It raised significant alarms. There were serious long-term concerns about pulmonary fibrosis, the decline of lung function, and the rapid formation of circulating insulin antibodies.
It was a bust.
Ultimately, patient demand was abysmal, and Pfizer withdrew Exubera from the market after losing billions of dollars. Afrezza, a much newer and better formulation, utilizes a tiny whistle-sized device and has better kinetics. But inhaled insulin remains a very niche therapy.
Why is that?
For the vast majority of patients, the sheer reliability, microscopic painlessness, and exact precision of modern, ultrafine insulin pen needles simply outweigh the unpredictable nature of inhaling a powder.
Fascinating. So the subcutaneous injection remains the undisputed king for type 1 diabetes and severe type 2. But this perfectly pivots our conversation entirely over to the other side of the aisle. Let's focus strictly on type 2 diabetes.
Where oral medications dominate.
Right. Now remember, many type 2 patients are still producing their own insulin. Their peripheral tissues are just actively resisting it. So rather than giving them more external insulin right away, which involves needles and carries a heavy risk of causing further weight gain, Pharmacology has developed an incredible array of oral drugs.
Pills that essentially hack the pancreas, the liver, and the cells to force the broken system back into compliance.
The pharmacological approach to type 2 is incredibly diverse. These oral medications are broadly categorized into two distinct camps: oral hypoglycemic agents and antihyperglycemic agents.
Understanding the clinical distinction between those two seemingly identical terms is absolutely crucial to understanding how we manage the disease safely.
Let's illustrate that difference by starting with the oldest and most aggressive class of pills, the sulfonylureas. The text mentions older first-generation drugs like tolbutamide and much more potent modern second-generation drugs like glibenclamide, glipizide, and glimepiride. Looking at their mechanism, I call this entire class of drugs the squeezers.
The squeezers is a highly accurate, if slightly violent, description.
Let's hear why.
To understand them, we have to revisit the elegant combination safe mechanism of the beta cell we discussed earlier. Normally, glucose enters, ATP rises, the potassium channel closes, the cell depolarizes, calcium rushes in, insulin goes out.
Right, the perfect lock-and-key cascade.
Well, sulfonylureas completely forcefully bypass the glucose part of the equation. These drugs circulate in the blood and physically bind to a specific binding site on that ATP-sensitive potassium channel, a site appropriately named the sulfonylurea receptor, or SUR.
SUR, got it.
When the drug binds to the SUR, it chemically forces the potassium channel to close.
Wait, so it just manually jams the electrical door shut regardless of whether there's actually any glucose or ATP present in the cell?
It completely overrides the cell's sensors. By jamming the potassium door shut, it forces the cell membrane to depolarize, forces the calcium channels to fly open, and forces the beta cell to violently dump its stored insulin granules into the bloodstream. It essentially wrings the pancreas out like a sponge, demanding insulin now.
So if we go back to my vending machine analogy, instead of putting in the correct change, which is the glucose, to gently persuade the insulin to fall out, a sulfonylurea is basically a guy walking up with a crowbar and physically kicking the vending machine until the insulin drops.
That is exactly what they do. And because they force the pancreas to secrete massive spikes of insulin, completely independent of the actual blood sugar levels, they are classified as true hypoglycemic agents. They actively, aggressively drive blood sugar down, sometimes far too well.
Which immediately illuminates the major risks. If I take a drug that kicks the vending machine, but I haven't eaten any food,
Then you are in extreme danger. The most common and most dangerous side effect of sulfonylureas is severe, life-threatening hypoglycemia.
that's scary.
If a patient takes a long-acting sulfonylurea like glibenclamide in the morning, but then skips lunch or goes for a long run, the drug doesn't care. It is still forcing insulin into the blood. Their blood sugar can plummet to fatal levels.
Just bottom out completely.
This is a particular nightmare in elderly patients whose kidney and liver function might naturally decline, causing the drug to dangerously accumulate in their system rather than being cleared.
The text also heavily notes weight gain as a guaranteed side effect of these drugs. Why would a pill designed to treat diabetes, a disease worsened by obesity, cause weight gain?
We have to remember what insulin actually is. It is the body's primary anabolic or storage hormone. Its entire job is to pull glucose out of the blood and pack it tightly away into fat cells and glycogen stores.
Oh, right, the storage hormone.
By constantly forcing insulin levels artificially high with a sulfonylurea, you are sending a 247 chemical signal to the body demanding that it store calories. This inevitably leads to increased fat deposition and weight gain, which, as you noted, creates a vicious cycle by worsening the underlying insulin resistance that caused the type 2 diabetes in the first place.
Okay, so kicking the vending machine works to lower numbers on a chart, but it's risky, it exhausts the pancreas, and it causes weight gain. This realization leads us directly to the undisputed heavyweight champion of type 2 diabetes management, the absolute cornerstone drug, metformin.
The big one I.
Right. The text classifies metformin under a chemical class called big one-ides. More importantly, it classifies it as an anti-hyperglycemic agent, contrasting it against the hypoglycemic sulfonylureas. What is the fundamental difference in how it treats the patient?
The clinical difference is profound. A hypoglycemic agent, like a sulfonylurea, will blindly drive blood sugar down, even driving it straight into a coma-inducing low. An anti-hyperglycemic agent like metformin operates differently.
Oh, so?
It acts to prevent blood sugar from climbing too high after meals or overnight, but it lacks the chemical ability to push blood sugar dangerously below the normal fasting baseline. It normalizes sugar, but it rarely crashes it.
So how does metformin pull that off without squeezing the pancreas for more insulin? Because
Mhm.
reading the mechanism, I am officially declaring metformin the efficiency consultant.
The efficiency consultant is a brilliant framework. Metformin is entirely unique because it does not stimulate insulin secretion whatsoever. It does not bind to the beta
So
cells.
the pancreas gets a break.
It doesn't care if the pancreas is exhausted. Instead, its primary mechanism of action is focused heavily on the liver and secondarily on the skeletal muscles.
Okay, the liver.
Remember our discussion about glucagon and how the liver constantly manufactures new sugar through gluconeogenesis to keep the blood supplied?
Yes, the emergency flare.
Metformin essentially walks into the liver's factory floor, looks the runaway production, and shuts it down. It alters the energy dynamics of the liver cells, mildly inhibiting their mitochondria, which profoundly suppresses hepatic glucose output.
So it physically stops the liver from dumping unneeded, newly manufactured sugar into a bloodstream that is already full of it.
Exactly. It cuts off the road's supply line. But it goes even further than that. Concurrently, metformin travels to the skeletal muscles and acts as an insulin sensitizer.
Making the muscles listen better.
It amplifies the action of the insulin that is already floating around, helping the muscle cells uptake and utilize glucose much more efficiently. Furthermore, it slightly slows down the absorption of carbohydrates from the gastrointestinal tract, flattening out post-meal sugar spikes.
Let me summarize the consultant's work. It cuts the unwanted supply of sugar from the liver, it delays the import of sugar from the gut, and it simultaneously increases the demand and burning of sugar in the muscles. It optimizes the entire metabolic factory floor without ever touching the pancreas.
It's an elegant solution.
And if you are listening with us right now, there is a very, very high probability that you, an older relative or a friend, swallows a metformin pill every single morning. It's ubiquitous.
It is ubiquitous for a very good reason. Because it does not force unnatural spikes of insulin, it does not carry the vicious side effect of weight gain. In fact, many patients experience mild beneficial weight loss when starting metformin.
Very nice bonus.
And crucially, when used alone as a monotherapy, the risk of it causing a severe hypoglycemic episode is virtually zero. It is incredibly safe.
But it's a medication, so there has to be a catch. What are the downsides to the efficiency consultant?
The most common side effects, which drive a significant number of patients to discontinue the drug early on, are entirely gastrointestinal.
Stomach issues.
Because it alters glucose absorption and interacts with the gut microbiome, patients frequently report anorexia and nausea, a strange metallic taste in the mouth, and most notoriously, profound diarrhea and abdominal cramping. These symptoms usually subside if the dose is titrated up very slowly, but they can be severe.
Is there anything more serious?
There is also a very rare but highly lethal metabolic risk called lactic acidosis. Because metformin mildly inhibits the mitochondrial respiratory chain in the liver, it can interfere with the liver's ability to clear lactic acid from the blood.
So it builds up.
In a healthy patient, this isn't an issue. But in patients with severe kidney disease, liver failure, or acute heart failure where tissues are already struggling for oxygen, lactic acid can build up to fatal levels.
Good to know.
But for the vast majority of the type 2 population, its safety profile, lack of weight gain, and incredible multi-organ effectiveness make it the absolute, undisputed first-line pharmacological choice globally.
Okay, so we have the brute force squeezers and the elegant efficiency consultant. The next class of drugs outlined in the text is a real mouthful. Thiazolidinaviones, mercifully shortened in clinics to glitazones.
Much easier to say.
Yes, we are looking at drugs like pioglitazone and rosiglitazone. Now, reading their mechanism of action, this is where pharmacology feels like it steps into the realm of science fiction, because this happens entirely on a genetic level, right?
The glitazones are a testament to how deep cellular biology can go. They don't just block a membrane channel like a sulfonylurea or tweak mitochondrial efficiency like metformin. They act as highly targeted agonists to a specific complex nuclear receptor located deep inside the cell,
Deep inside.
called PPR gamma, which stands for peroxisome proliferator activated receptor gamma.
That's a mouthful, too.
This specific nuclear receptor is expressed heavily in adipose tissue fat cells, as well as skeletal muscle and the liver.
I want to make sure I understand this. A nuclear receptor. So when the pioglitazone molecule binds to this receptor, what exactly happens inside the cell?
It physically alters the gene transcription of the human body. When the drug binds to PPAR gamma, the receptor complex enters the nucleus of the cell, binds to the DNA, and actively turns on the transcription of specific insulin-responsive genes that control glucose and lipid metabolism.
Think back to the GLUT doors we talked about earlier, the transporters that let glucose inside.
Exactly. The glidosomes go into the DNA and command the cell to manufacture millions of brand new GLUT4 transporters and embed them into the cell surface.
They're literally hacking the DNA to build more doors for the sugar.
They are. By forcing the fat and muscle cells to drastically increase their number of GLUT4 doors, the glidosomes massively, profoundly increase the entire body's sensitivity to circulating insulin. They tackle peripheral insulin resistance at its absolute genetic root cause.
That sounds like the holy grail of diabetes treatment. If they fix the genetic resistance, why aren't these the first-line drugs instead of metformin?
Because hacking the genetic transcription of fat cells across the entire body carries massive systemic consequences.
Like what?
While the glucose-lowering mechanism is elegant, activating PPAR-gamma also turns on genes that regulate fluid balance. The most significant and dangerous side effect of glidosomes is severe fluid retention and edema.
So why?
The blood volume rapidly expands, which forces the heart to pump much harder. In patients with underlying cardiac issues, this fluid overload can directly precipitate or severely worsen congestive heart failure.
Flooding the engine to fix the fuel line.
Exactly. Furthermore, there's a paradoxical side effect of weight gain, not just from the retained water weight, but because activating PPAR-gamma actively promotes the differentiation of new fat cells, increasing subcutaneous adiposity.
Making new fat cells.
The history of these drugs is actually quite dark. Rosiglitazone, once a blockbuster drug, was heavily restricted and withdrawn from several global markets due to clinical data suggesting it significantly increased the risk of myocardial infarction or fatal heart attacks.
Right.
Pioglitazone is still used today, but with extreme caution, absolute contraindication in heart failure patients, and constant monitoring. Additionally, because they rely on physically altering DNA transcription and building new proteins, they are not quick fixes. It takes several weeks to months for the insulin-sensitizing effects to fully develop.
It's a perfect, sobering example of how incredibly powerful these medications are. You tweak the genetics of fat cells to perfectly fix the blood sugar, but you accidentally overload the heart with fluid and cause a heart attack. It is such a fragile, terrifying balance.
It really is.
Let's quickly touch on one more older, slightly comical class of oral drugs mentioned here, the alpha-glucosidase inhibitors. Things like acarbose. How do they attempt to control the sugar?
Acarbose ignores the pancreas, the liver, and the cells entirely. It works strictly in the lumen of the gastrointestinal tract. Normally, when you eat complex carbohydrates like the starch in potatoes or bread enzymes in the brush border of your small intestine called alpha-glucosidases, have to meticulously chop those long starches down into simple single glucose molecules.
So they can cross over.
Right, so they can be absorbed across the intestinal wall and into the blood. Acarbose acts as a competitive inhibitor of those exact enzymes.
So it just physically blocks the scissors that digest the carbs?
Yes, it chemically blunts the scissors. It doesn't stop digestion entirely, but it delays it significantly.
Smoothing out the spike.
So instead of a massive rapid spike in blood sugar 30 minutes after eating a meal, the carbohydrate digestion is drawn out and spread over hours, effectively lowering and flattening that dangerous post-meal glycemic peak.
That sounds great in theory, but my immediate question is, if the carbs aren't being digested and absorbed in the small intestine where they belong, where do they go?
And that is the exact reason this drug is rarely prescribed today. Because they aren't absorbed in the small intestine, those massive loads of undigested complex carbohydrates travel further down into the large intestine, the colon.
Oh, no.
The colon is packed with your natural gut microbiome, trillions of bacteria. When those bacteria are suddenly presented with a feast of undigested sugars, they ferment them rapidly.
Which means gas.
This bacterial fermentation produces massive, uncontrollable amounts of intestinal gas. The resulting side effects, profound flatulence, explosive diarrhea, and severe abdominal cramping, are so universally unpleasant and socially debilitating that acarbose is very poorly tolerated by almost all patients.
Mental note. If you are prescribed acarbose, do not take it before a first date or a long road trip. Okay, so we've covered the legacy pills, the squeezers, the consultant, the genetic hackers, and the gas pills. Now we arrive at the final frontier of our deep dive.
The cutting edge.
This is where medical science stops looking just at insulin and the pancreas and starts exploring entirely different, unexpectedly brilliant biological pathways. We are looking at hormones from the gut, filtration in the kidneys, and even intercepting the immune system itself.
It's an exciting time in the field.
Let's start with a group of drugs that have completely taken over not just medicine, but the entire cultural conversation in Hollywood lately. The GLP-1 agonists, or incretin mimetics. To understand them, we have to define the root word. What on earth is an incretin?
Incretins are a class of metabolic hormones, specifically GLP-1, glucagon-like peptide 1, and GIP. They represent an entirely different signaling pathway. When you eat a meal, the physical presence of nutrients hitting the lining of your upper and lower bowel triggers special endocrine cells in the gut to immediately secrete these incretin hormones into the blood, long before the glucose itself is even fully absorbed.
So the gut is sending an early warning text message to the pancreas. Hey, a massive carbohydrate load is coming down the pipe. Get ready.
That is exactly their function. GLP-1 travels rapidly to the pancreas and binds to the beta cells, massively amplifying their sensitivity to glucose. It essentially primes the pump, ensuring a robust early release of insulin.
And what about the alpha cells?
Concurrently, it binds to the alpha cells and actively suppresses the release of glucagon, preventing the liver from adding to the incoming sugar pile. But the magic of GLP-1 goes far beyond the pancreas. It acts locally on the stomach to significantly slow down gastric emptying. It keeps the food in the stomach longer, ensuring the sugar trickles into the blood rather than hitting it like a tidal wave.
Which helps with the spikes?
And perhaps most famously, GLP-1 crosses the blood-brain barrier, travels up to the satiety centers in the hypothalamus, and actively, aggressively suppresses the sensation of appetite.
Let me get this straight. It boosts insulin, suppresses glucagon, slows down digestion so you absorb sugar slower, and physically wires your brain to make you feel full.
It does all of that.
It is a biological miracle molecule for a type 2 diabetic. Why did it take us until the 2000s to just give people GLP-1 pills?
The problem wasn't knowing what GLP-1 did. The problem was the molecule's terrifying fragility. Natural endogenous human GLP-1 is incredibly unstable. It has a circulating plasma half-life of roughly 1 to 2 minutes. The absolute second it is released from the gut, a ubiquitous enzyme floating in your blood called DPPIV. Dipeptidyl peptidase 4 aggressively attacks and cleaves the GLP-1 molecule, rendering it totally inactive.
So it's an assassin.
If a doctor simply injected a vial of pure human GLP-1 into a patient, the DPPIV enzyme would completely destroy it before it ever reached the pancreas or the brain.
So the pharmacologists had a puzzle. They needed to find a version of GLP-1 that could act like the human hormone, but was somehow physically immune to the DPCIV hitman enzyme in the blood.
Exactly.
And this is where I need you to explain the most insane, reality-defying fact I read in this entire document. Exenatide. Tell me the story of the Gila monster.
It sounds like pure science fiction, but it is one of the greatest triumphs of modern bioprospecting.
I am ready.
Researchers in the 1990s were testing various natural venoms and toxins looking for bioactive peptides. They analyzed the venomous saliva of the Gila monster, a large, slow-moving lizard native to the deserts of the American Southwest.
Okay, a lizard.
They discovered a specific peptide in the lizard's venom named exendin-4 that shared roughly 50% of its amino acid sequence with human GLP-1.
Half human, half lizard.
When they tested it, they found that it bound perfectly to human GLP-1 receptors, triggering all the massive benefits of insulin release and appetite suppression. But the absolute miracle was the structural difference. Because of a few specific amino acid substitutions unique to the lizard, exendin-4 was completely 100% resistant to degradation by the human DPPIV enzyme.
Hold on, let me just sit with this and make sure the listener is absorbing this reality. We are using the spit of a venomous desert lizard to help human beings process the carbohydrates in their sandwiches, because the lizard spit is biologically indestructible in human blood.
That is precisely what we are doing.
That is absolutely unequivocally wild.
It is a stunning example of evolutionary biology solving a pharmacological roadblock. Pharmaceutical companies synthesized this exact lizard peptide to create the blockbuster drug exenatide. When a patient injects exenatide subcutaneously, it causes all those beneficial incretin effects, but because it ignores the DPPIV enzyme, it lasts for hours instead of minutes.
And that kicked off the whole trend.
The success of exenatide proved the concept and paved the way for the newer, purely synthetic, highly modified human GLP-1 agonists that dominate the market today. Drugs like liraglutide, dulaglutide, and semaglutide.
Ozempic and Wegovy.
Exactly. By continuously tweaking the molecular structure and attaching fatty acids to bind to albumin, similar to what we saw with insulin. Gedimier scientists have extended the half-life so dramatically that these newer drugs only require a single injection once a week.
And because they slow gastric emptying and actively act on the hypothalamus to shut down the hunger drive, these are the exact drugs that are famous right now for inducing massive, unprecedented weight loss alongside their blood sugar control. It's a total revolution.
It really has changed everything.
Now, if a patient didn't want to inject modified lizard venom or weekly peptides, the text outlines another, sneakier way to manipulate this exact same incretin system: the DPP-4 inhibitors.
Yeah.
These are oral drugs like sitagliptin and vildagliptin. How do these pills tackle the problem?
Sitagliptin takes the exact opposite but equally logical approach. Instead of trying to introduce an indestructible alien version of GLP-1 into the body, it simply targets the enzyme that is causing the problem.
The Hitman enzyme.
Yes. These drugs act as highly specific inhibitors of the DPPIV enzyme itself.
It's basically taking out the Hitman so the VIP can walk freely.
Precisely. By chemically disabling the DPPIV enzyme, sitagliptin allows the patient's own natural endogenous incretin hormones to survive much longer in the circulation, effectively doubling or tripling their active levels in the blood after a meal.
Boosting what you already have.
The beauty of DPP-4 inhibitors is that they are simple, once-daily oral pills, and they are incredibly well tolerated with very few side effects.
Yeah.
However, because they only amplify what the body naturally produces, they are generally much less potent than the injectable GLP-1 agonists, and they do not cause the same dramatic headline-making weight loss.
Okay, moving from the gut hormones, we travel down to the filtration system. This next class of drugs completely flips the script on the fundamental philosophy of how we treat diabetes. I am talking about the SGLT2 inhibitors, drugs that end in gluflozin, like the pagliflozin, canagliflozin, and empagliflozin.
Gluflozins, yes.
Every single other drug we've talked about for the last hour is trying to help the body use the sugar, or force the liver to stop making the sugar. SGLT2 inhibitors look at the problem and ask a completely different question. What if we just throw the sugar in the garbage?
The development of SGLT2 inhibitors represents a massive paradigm shift in endocrinology. To understand them, we have to revisit the kidneys.
Back to the filters.
Remember when we discussed polyuria? And we established that the kidney constantly filters all the glucose out of the blood. We noted that normally, the kidney aggressively reabsorbs almost 100% of that glucose back into the bloodstream because the body views calories as precious survival resources.
Right.
The specific biological doorway responsible for pulling that sugar back into the blood is a transport protein located in the proximal tubule of the kidney called the sodium glucose transporter 2, or SGLT2.
Right. It's the biological vacuum cleaner making sure no sugar is accidentally lost in the urine.
Exactly. But in a modern type 2 diabetic patient who is drowning in toxic excess glucose, that highly efficient vacuum cleaner is actually killing them. It is returning the poison back to the blood. So SGLT2 inhibitors do exactly what their name implies. These oral pills travel to the kidney and physically block that specific SGLT2 transporter.
So the blood flows into the kidney filters the massive load of sugar out, goes to reabsorb back into the blood, finds the SGLT2 door completely locked, and just, shrugs and flushes it down the drain.
Yes, exactly. The excess glucose is trapped in the urine and is simply excreted from the body into the toilet. It physically, mechanically removes the sugar from the patient's system, entirely independent of insulin, independent of the pancreas, and independent of genetic cellular resistance.
That is just hilariously pragmatic. You bypass the broken pancreas, you ignore the insulin resistance, you just pee out the problem. What are the clinical benefits of just throwing the sugar away?
The benefits have proven to be profound, extending far beyond simple blood sugar control. First, because the patient is literally urinating away up to 70 or 80 grams of pure glucose a day, they are physically losing hundreds of calories.
Which means weight loss.
This leads to steady, reliable weight loss. Second, because the SGLT2 transporter also pulls sodium back into the blood along with the glucose, blocking it causes a mild diuretic effect. The patient excretes excess sodium in water, which significantly lowers their blood pressure.
A huge deal for diabetics.
A massive cardiovascular benefit for diabetics who almost universally suffer from hypertension. And finally, unlike the sulfonylurias that kick the pancreas, SGLT2 inhibitors carry a very low risk of hypoglycemia, because as blood sugar drops to normal levels, the kidneys naturally filter less of it, creating a self-regulating floor.
Okay, I hear the benefits, but my biological common sense is screaming right now. There has to be a catch. Flushing pure, concentrated syrup through your dark, warm urinary tract every single day cannot be consequence-free.
Your biological common sense is spot on. The primary, most frequent side effect of SGLT2 inhibitors is a drastically increased risk of genitourinary infections, specifically urinary tract infections and severe mycotic or fungal infections like candidiasis.
Because of the sugar.
Bacteria and yeast absolutely thrive in dark, warm, high-sugar environments. By taking this drug, you are effectively turning the urinary tract into a highly sweetened culture medium. Patients have to maintain immaculate hygiene. There's also a slight diuretic effect that can lead to dehydration or postural hypotension if the patient isn't drinking enough water.
Drink your water, people.
But clinically, their massive proven cardiovascular and renal protective benefits have made them revolutionary, life-saving mainstays in modern diabetes care.
We have time to touch on a few more fascinating, very recent developments mentioned at the very end of the text. One of them is a drug called bromocriptine. Now, I recognize that name from neurology. It's a dopamine agonist used for Parkinson's disease. What is a Parkinson's brain drug doing in a chapter on diabetes?
It highlights just how interconnected the body's systems truly are. It's a fascinating neurological angle on metabolic disease.
How does it work?
While the exact granular mechanism is still being elucidated, researchers discovered that administering a quick-release formulation of bromocriptine early in the morning activates specific dopamine receptors in the hypothalamus of the brain.
The brain clock.
This activation seems to reset abnormal circadian hypothalamic rhythms. By modulating this deep brain circuitry, it sends descending neural signals that suppress the liver's glucose production and subtly increase peripheral insulin sensitivity. It doesn't change insulin levels directly. It literally hacks the brain's internal clock to change how the brain talks to the liver.
Hacking the brain's clock to fix the liver to cure the blood sugar, the web of biological connections is just endless.
It really is.
But the final two drugs we need to discuss are truly looking past the horizon. They represent the absolute future of the field. Let's look at teplizumab first. Now, this isn't an oral pill, and it's not a daily insulin shot. This is a monoclonal antibody. And crucially, it's used for type 1 diabetes, which we establish is the autoimmune disease where rogue T cells hunt down and destroy the pancreas. How does an antibody treat that?
Teplizumab is a masterpiece of targeted immunology. It is a humanized IgG1 monoclonal antibody that is engineered to specifically seek out and bind to the CD3 chain complex located on the surface of human T cells.
Okay, the CD3 chain.
Now, the T cell receptor is the weapon the immune system uses to recognize foreign antigens and launch a lethal attack. By binding a massive antibody directly to the CD3 chain next to that receptor, teplizumab creates profound steric hindrance.
Steric hindrance.
It physically clumsily blocks the T cell from being able to lock on to and recognize the pancreatic beta cell as an enemy.
Wait, it acts like a biological shield. It stops the immune system from attacking the pancreas.
It actively intercepts the autoimmune attack before it can finish the job. Teplizumab is a watershed moment. It is the very first pharmacological treatment ever approved by the FDA to actually delay the clinical onset of type 1 diabetes in high-risk patients.
Delay the onset.
If you catch a patient early enough when their immune system has started the attack, but they still have some surviving beta cells, an infusion of teplizumab interferes with that T cell activation. It preserves whatever natural beta cell function the patient has left, delaying the need for lifelong insulin therapy by months or sometimes years.
That is a staggering, monumental breakthrough. We aren't just replacing the missing insulin anymore. We are actually wading into the immune system and stopping the disease process itself from happening.
It's a completely new era.
And speaking of entirely rewriting the rules of the game, the final drug mentioned in the clinical updates is tirzepatide. Looking at its profile, it sounds like the terrifyingly powerful evolution of the GLP-1 incretins we talked about earlier.
It is the next evolutionary leap. Tirzepatide is what we call a dual agonist. It doesn't just mimic GLP-1, it is a single, highly engineered molecule that simultaneously mimics and binds to the receptors for both GLP-1 and GIP, the other major incretin hormone we briefly mentioned.
Double the incretins.
By agonizing both of these distinct incretin receptors at the exact same time, it creates a profound synergistic metabolic effect. The clinical trial results have been astonishing. It results in even lower fasting blood sugars, even flatter post-meal spikes, and most notably, even more dramatic, unprecedented reductions in appetite, food intake, and overall body weight than the single GLP-1 agonists alone.
The ultimate weight loss tool.
It is rapidly redefining what we thought was possible with pharmacological weight and metabolic management.
Wow, okay. We have covered an immense, staggering amount of ground today. We started by exploring the delicate evolutionary tug-of-war between the alpha and beta cells in the tiny hidden thermostat of your pancreas.
The islets of Langerhans.
We decoded the intricate combination-safe mechanism of how a single beta cell actually metabolizes your food to release insulin. We looked at the devastating, acidic, system-wide cascade of diabetic ketoacidosis and the slow, insidious cellular damage of high blood sugar.
System failure.
And then we marveled at the sheer relentless ingenuity of modern pharmacology, from tweaking amino acids to make insulin crystallize under the skin, to wrapping it in fish proteins, to harvesting the indestructible venom of desert lizards, to drugs that just force your kidneys to urinate out the problem entirely.
And through all of that staggering complexity, what stands out most clearly to me is the sheer resilience and the microscopic intricacy of the human body. Every single time you sit down to eat a meal, billions of beta cells inside you are simultaneously taking glucose measurements, generating ATP, altering their electrical gradients, and firing calcium channels just to keep you alive, stable, and healthy.
It's poetry, really.
The fact that medical science has decoded this silent symphony well enough to actually step in, take the baton, and conduct the orchestra when the natural players fail is, without question, one of the greatest collaborative achievements in human history.
It absolutely is. And it leaves me with this final provocative thought for you, the listener, to mull over on your own as you go about your day. We ended this massive journey by discussing cutting-edge drugs like teplizumab, which literally intercepts and disarms the autoimmune destruction in type 1 diabetes, and tirzepatide, which completely chemically rewires the gut and the brain's fundamental response to food. If we're now creating therapies that can successfully modulate the human immune system and rewrite our fundamental metabolic programming, are we finally approaching an era where we no longer just manage the symptoms of diabetes with external insulin and daily pills?
A cure, essentially.
Are we actually on the precipice of being able to reprogram the body to prevent the disease from taking hold in the first place? It's no longer just about fixing the broken hardware of the machine. It feels like we are learning how to upgrade the software before it ever has a chance to crash.
That's a profound thought to leave on.
Something to ponder the next time you look down at a sandwich on your plate or read a headline about the latest medical breakthrough. Thank you for joining us on this incredible microscopic journey through the body's energy grid. Keep asking questions, keep wondering how the invisible things work, and we will see you on the next deep dive.